Hello, everyone. We are live now. Welcome to today's teaching event from SIGAF General Surgery Community. Here with me is Mr. Oyekan, who is going to be the speaker for tonight's teaching. It's acute appendicitis. Could you just indicate in the chat box if you can hear me clearly? Just need confirmation that everyone can hear me. Can everyone hear me? Okay, perfect. I think I've got an answer on the chat box or in the chat box saying I'm audible. Mr. Speaker, I'm I'm going to be putting you on now in a couple of minutes, but we just wait for a few more minutes for others to join. We just give them like say the next 5 minutes thereabouts, just because there's an event that just finished not quite long, and everyone on that event also would like to join these. So I think they've just rounded off. So we'll just give them a bit of time to join us, if that's all right. So I'm gonna go mute for a couple of seconds or minutes, and I'll come back to you guys. We would be starting at 7:15 on the dot officially. We'll just be waiting for others to join in. Okay. Hello, everyone. We're back and we'll be starting right away. Sorry and apologies for taking a bit of time. We just needed to do that so that we could get others to join in. Reason being that there was an event earlier on that just rounded up, and we wanted the attendees of that event to also participate fully in this event. So I'll be introducing our speaker right away, and shortly after then, he would take over the stage. You can check the polls for questions and you can put in your answers. And also, I believe you all would get a feedback form to be filled after the session. Make sure you do that because that's the only thing that will give you access to the certificates that we will be issuing after the session today. So my name is Oluwasina Dada. I'm the SIGAV General Surgical Lead, and SIGAV stands for Surgery Interest Group of Africa. We've got lots of communities in SIGAV. General surgery is just one of them, and at present is the most populous community in SIGAV. So if you want to join SIGAV, I'll put a link in the chat box at some point, and you can, if you're not a member yet, you can click the link and you'll be able to join. It's so straightforward. You can join whichever community you want to join. And basically, today's session is going to be anchored by Mr. OYEKAN. He's Oluwaseun Akeem OYEKAN, who finished from lawsuits as the best student, how do you call that? Oh, my tongue is twisting now. Help me, someone. Actually, so he finished as the valedictorian, if I'm correct. I don't even know anymore. So I think I had a lot of food, not quite long. My brain is sleeping. So we've got the opportunity to be having this session anchored and delivered to us by the best student in lawsuits in 2017. He's presently in the UK, and he's a clinical fellow at the Frimley Park Hospital in UK. He's also a member of the Royal College of Surgeons of England. So with no further ado, I would bring up to the stage Mr. OYEKAN to drive the bus. Thank you. You can unmute yourself, sir.
Yeah, good evening. Thank you very much, Dr. Oluwasina. The name sounds like my Oluwasina. Anyway, it's nice to be here. Good evening, everyone. My name is Oluwaseun Akeem OYEKAN, and I'm here today to have a chat with us about acute appendicitis. Just a friendly chat. And I think you can always stop me or mute yourself if there's any clarification you want during the presentation, or you can decide to wait till the end for the questions or clarification. I think anyone is fine by me. And yeah, Dr. Oluwasina has already introduced me. I don't think I need to do anything more about that. Once he says he's ready, I'll share my screen and we can start. I can't see how many people are currently on though, but let me see. If we are ready to start.
Yeah, so we've got at the minute we've got
I think I
20.
can see it now.
We've got about 20 on the call. I'm sure other people will still join. Yeah.
So if you want me to start, just let me know. I'll start. as soon as you say
Yeah,
so.
please feel free to start and share your screen, sir.
Yeah. Can you hear me?
Loud and clear.
And can you see my slide?
Yeah, very clearly.
Okay. Yeah, that's fine then. Good. Okay. Once again, my name is Oluwaseun Akeem OYEKAN, graduated from LASU in Ikeja, Lagos, Nigeria. And we can move on. So, as an introduction, um, I'm sure every single person will have heard or seen a patient with acute appendicitis, whether confirmed or as a differential diagnosis. And it is the most common general surgical pathology in all parts of the world. No matter where you come from, acute appendicitis will always stop in terms of a general surgical diagnosis. And as a trainee, I think that's one of the main surgical procedure that we all want to do as the first main surgery. And I think that's the first one a consultant um, will feel the ease to let you do, whether supervised or non supervised. But as very common as it is, and as very well known, I think it still causes significant morbidity and mortality from it, especially when it is not diagnosed early, or even when diagnosed for whatever reason there is delay in intervention. But before we move into the inflammation itself, I just take a brief minute to talk about the appendix. The full name is the variform appendix, and it's a worm-like diverticulum that arises from the posterior medial wall of the cecum, very close to the ileocecal junction. In terms of its size, diameter, and position, it varies. Not just with age, even in the same age group, you have it in different size, diameter, and position. And I can tell you, you can have an appendix as long as 20 centimeters. And I've seen some appendectomy done with a very, very large and dilated appendix. You almost think it's another organ entirely. It is usually intraperitoneal. It has its own mesoappendix, which is very important in the surgery and the dissection to remove the appendix. And it is supplied by a single end artery, the appendicular artery, from the ileocholic artery. I will show us this. I hope you can see my cursor. So if this is the appendix, then the whitish stuff here will be the mesoappendix, and the appendicular artery run along its free edges. So it is an end artery. So in any thrombosis occurring within the appendicular artery, the tip of the appendix will suffer most. Lymph nodes from the appendix and all the surrounding structures usually will end up in the ileocholic node, very close to the appendix. And this is very important because of some differential diagnosis that we usually come across in acute appendicitis. And in terms of position of the appendix, as you can see, we have all sort of position, but the most common is the retrocecal, when the appendix goes behind the cecum, and you probably need to fling the cecum to be able to access the appendix. That occurs in 74% of the time. I think the next one will be the pelvic, also the 4 o'clock that points directly into the pelvis. Probably can be on the bladder, just beside the rectum, in between both the bladder and the rectum, but that is the second one. But as you can see, there are so many variations of this position. Histology is just like any other part of the bowel for mucosa, submucosa, muscularly, and the serosa. But the histology is more renowned because of the lymphoid follicles, which some individuals have postulated that this is actually the function of the appendix to help with immunity. Well, there are some questions here, just some brain teasers, just for us to something to think about before we start the main presentation. I don't know if Dr. Dada can bring up the pool now, or I have to be the one to do it.
Yeah, I can bring it up. Do you want this particular one you're sharing now, or
Yes, this particular one, 25-year-old
okay,
male. Yeah,
25-year-old. So I don't think we've got this particular one.
okay. I think I'll just bring it up. Um,
Do you want to include it yourself now?
yeah, I think, yeah. No,
Okay.
it's already included. I just need to.
We've got a 70-year-old one, but not the 25-year-old one.
Yeah, okay. I think I did something like this.
Okay.
Yeah, I didn't include the whole question.
Okay, so the one
I brought it up already. I don't know if every other person can see this.
so the one we are seeing now is what type of organism is the culprit in acute appendicitis? Is that what you
Yes,
want?
yes, that is what I want. And
Okay.
the
Yeah.
question is already on the screen. So it's about a
Yeah.
25-year-old male with migratory right iliac fossa pain. He has some fever, is nauseous, anorexic. On examination, rebound tenderness in the right iliac fossa, leukocytosis, and the clinician felt this was acute appendicitis, and he decided operative management was the way to go. But sometimes during appendectomy, we usually, sometimes very rarely, take peritoneal fluid for MCS. And I just wanted to know if we have any idea what type of organism is usually grown in patients with acute appendicitis.
So we've got some answers already. Just waiting for others to put in their answers. So we give it a few more seconds. In the next 10 seconds, we would carry on with whatever answers we've got. Yeah, the answers are coming in.
We're just trying to make it as interactive as possible. There are quite a few questions. Um,
Can I just double check with us if anyone has got access to the mic to unmute themselves? Has anyone got access to the mic to speak? Just want to be sure. You might not, but again, we're just test running a particular function in this event, and that might give few persons access to use the mic. If you're able to use the mic, just put it on the. You can unmute yourself and talk, and of course, I'll get a confirmation from there. If you're not, if I don't get anyone talking, then I'll assume no one has got access to the mic. So you can just put your questions, your comments, and everything you want on the chat box, and we'll pick it up from there. You can begin to ask your questions now as the speaker goes on with the teaching. or you can wait till the end. So yeah, we've got the polls already. Do you want me to let everyone know what results we've got?
Um, I think we can wait to the end. Yeah,
Okay, till the end. Okay, fine,
yeah,
fine,
we'll wait to the end.
perfect. So we
Yeah,
just
I
we
think
just leave it there.
we'll just collate the answers and then we'll wait to the end to see what
Okay,
people
fine,
thought before
fine,
the
fine,
presentation.
perfect.
Yeah. Okay.
Okay,
Yeah,
no
thank
worries
you.
at all. Carry on. Thank
Yeah, and another question is, in terms of the pathogenesis of acute appendicitis, which of the following do we think cannot cause acute appendicitis? Because it has a pathophysiology.
you. So the second poll is on. If you want to cast your votes, you've got 5 options. The following can cause acute appendicitis, except A. Fecality, B. Intestinal worms, C. Cecal tumor, D. Fruit and vegetable materials, E. Excessive large meals. So we'll give that another 10 seconds and the speaker will carry on as well.
Moving on. Acute appendicitis can resolve by itself without surgery or the use of antibiotics. Do we think that is true or false? Do we think acute, an ultrasound, for example, an ultrasound confirmed acute appendicitis? Do we think it can resolve by itself without surgery or the use of antibiotics?
Yeah, so that's also live now. The poll is live. Cast your vote for either true or false. Give it another 15 seconds and the speaker will carry on. Thank you. Can carry on, please.
It's anonymous. It's anonymous anyway. We just want to see what people feel. Um, so question 4. A 3-year-old boy with a day history of abdominal pain has fever of 40 degrees. He has also had an upper respiratory tract for the past week. And on examination, he was mildly tender in the right iliac fossa, but it was not guarding. There was no rebound tenderness. White cell was normal, and there was no neutrophilia. Do we think this history is in keeping with appendicitis, or do we think it's probably another history? Patient doesn't have any diarrhea, doesn't have any urinary tract symptoms, no dysuria, no diarrhea, or anything else. Just abdo pain in the right iliac fossa, a day history, 40-degree fever, some upper respiratory tract infection with it. And if yeah, because we do see a lot of children, um, maybe up to 5 years. This can this can occur as a form of presentation in a lot of patients for a surgical review. Most times, the pediatrician wants us to rule out acute appendicitis. Uh, this is not part of the pool, so I'll just run over it. A 20-year-old male with migratory right iliac fossa pain has fever, nausea, is anorexic, had rebound tenderness on examination in the right iliac fossa. He has leukocytosis. What do we usually do to confirm the diagnosis? I'm sure everyone sees this in whatever practice they do. Question 6 is part of the pool. 70-year-old male with migratory right iliac fossa pain, fever, nauseous, anorexic, had rebound tenderness in the right iliac fossa, leukocytosis. How will you confirm this diagnosis? What investigation will give you a diagnosis in this patient?
So all the polls
Okay.
are still live. Even if you've not voted for the previous ones, you can check the chat box and still cast your votes. So for the last one, I think we've got fewer responses at the minute. So I will need you guys to vote more to get more. Yeah, I think it's coming up now. The 70-year-old one, we can also put our answers in the chat box because it's not part of the poll. So we can just put our answer in the chat
No, I
box.
think the 70-year-old should be part of the pool.
Sorry, the 20-year-old I was going to say. Apologies.
Okay.
The 20-year-old, you can possibly go back to the slide for the 20-year-olds just so everyone sees that again. They can just pop the answers in the chat box.
Acute appendicitis is a very popular topic, so I'm sure everyone have a very good idea of the questions even before the presentation.
Yeah, I think you can continue, boss.
Okay. Yeah, we'll come back at the end to have a look at this. So, acute appendicitis. I'll try not to take too much of our time, but in case I'm going too fast or there's something that we don't understand, we can always interject or we can decide to wait to the end. So, as a form of epidemiology, acute appendicitis is relatively rare in infants. I don't think it's an infant diagnosis, but become increasingly common in childhood and early adult life. And it peaks in early 20s, but I think usually most tests will say it peaks between 20 to 30. But I would say this is a disease of adolescents and very young adults. After middle age, the risk of developing acute appendicitis is quite very small, but somehow we still see 60-year-old, 70-year-old coming with acute appendicitis. The incidence of appendicitis is equal among male and female before puberty. After puberty, there is a little bit more male than compared to female. In terms of etiology, in no unifying hypothesis, but we've been able to culture fluids in patients with acute appendicitis. There've been a lot of research on it. There are some There are some meta-analysis with about 1,000 patients with acute appendicitis that had their peritoneal fluid cultured, and the most common organism was E. coli, but enterics generally. But even though gram-negatives are the ones being cultured more often, it is actually a mix of both aerobes and anaerobes. So in terms of active appendicitis, causative organism, it will be mixed, majorly gram-negative with anaerobes, and which is why our antibiotic therapy needs to cover both anaerobes and gram-negative, even though a little bit, maybe about 2%, can also be caused by gram-positive in addition to the anaerobes and anaerobes. But the major pathophysiology is that there is luminal obstruction of the appendix. The appendix, as we know, is blind. It has a lumen just like any other bowel, and anything, any material can enter into the lumen and obstruct the appendiceal lumen. Most commonly, this is done by fecolate, but any other structure has also been found to cause this. Any foreign body, meals, bones, little bones, as long as they can navigate their way into the very narrow appendiceal lumen, then they can cause obstruction. And which is why when they enter into the lumen, if they cause obstruction at the middle of the appendix, then the acute appendicitis happen in the distal end, not the whole length of the appendix. If the obstruction occurs just at the beginning of the appendix, then most of all the appendix throughout its length will then be inflamed. Strictures, foreign body. I have witnessed an appendectomy in a child. We made a cut on the appendix after dissecting and we're almost done. And immediately we cut the appendix, worms were entering into the peritoneal cavity. It was really gross, I'm sure you can imagine. Loads of very tiny worms. So worms could also obstruct. A cecal pole tumor, if there's a tumor in the cecum very close to the opening of the appendix, or the tumor migrates towards the opening and obstructs it, that can also cause acute appendicitis. Because once this happens, the appendiceal mucosa keeps on producing mucus. The mucus distends the appendix. The mucus cannot backflow because of the obstruction. This causes an increased pressure within the appendiceal lumen. The pressure eventually will cause a collapse of the venous system because there are low pressure flow. But if the obstruction continues because of the increased secretion of mucus, the mucus gets infected, just like any species of any fluid in the body. It gets infected, and then later on, the appendiceal wall gets inflamed because of the ongoing infection, and eventually, the pressure within the lumen then obstructs the artery. And once the artery is when the flow of the appendiceal artery is reduced, then there's ischemia of the tip, like we said, it's an end artery of the tip of the appendix. It becomes ischemic, gangrenous, perforate, and release the pus, which is the mucus that has now been turned to pus by the bacteria acting on it. And in terms of, if you're wondering what a fecolate is, a fecolate contains of some is inspissated, which means very dry fecal material that is mixed with some calcium salt, a lot of bacteria, of course, the epithelial shedding also. Everything together forms a fecolate, and it is usually very radio opaque. On X-ray, CT scan, you can always see fecolate very radio opaque because of the calcium content. And in most cases, that is what obstructs the appendiceal lumen. But One other very important cause of obstruction, different from foreign body or something physical entering into the lumen, is lymphoid hyperplasia. Just like you said, the appendiceal histology we showed earlier is renowned because of the presence of the lymphoid follicles. So when we have some respiratory illnesses, viral viremia, or for whatever reason, this lymphoid tissue or lymphoid follicle within the appendiceal mucosa can multiply, lymphoid hyperplasia, and this multiplication makes the mucosa more swollen, and then they can occlude the narrowing. So the lymphoid in the two wall of the appendix, because the appendiceal lumen is actually quite very small, usually about 2 millimeter. So the hyperplasia going on the two mucosa engorges the mucosa, and that can also close the lumen. If the whatever viremia or whatever causing the immune to respond, if that is abated, well, the lymphoid hyperplasia can resolve. Whatever is in the appendiceal lumen can drain. But if that doesn't happen, the same pathophysiology that we've explained will then happen and cause acute appendicitis. And it is because of this that we have two main forms of acute appendicitis. I think this is very important to know. And that is what we call the obstructive and also the non-obstructive. And the non-obstructive is also called the catarrh, like someone having an upper respiratory tract infection. The viremia from whatever cause can cause the lymphoid hyperplasia. Or if not the lymphoid hyperplasia, it could be directly from a physical body, which we've explained, causing the obstruction. We've already explained how the ischemias will occur, but if we remember our anatomy, the policeman of the abdomen, which is the greater omentum, it goes everywhere there is inflammation. So if there is an inflammation in the appendix, it goes there, far to it, perforating, it goes there and wraps around it. So even though there is a perforation, the greater omentum is already covering it so that that can limit the spread of purulent materials and the like if the appendix eventually perforates. But this caused something also. In even though the greater momentum is trying to do a great job being the policeman, it can form a phlegmonous mass. And what this means is that while trying to wrap the appendix, it can wrap the cecum with it can wrap the terminal ileum with it, and everything becomes a mass in there. And within the mass, if the appendix successfully ruptures, pouring out the pus in it, then it can form an abscess also within the mass. Very rarely, appendiceal inflammation can resolve, and when it resolves, the pus within it can become cleared to leave just the appendix itself filled with mucus. And that is what we call a mucocele of the appendix. You have an obstruction in the appendiceal lumen. The only thing you have in it is mucus, no bacteria, no infection. Whatever inflammation that was starting initially did not progress. It has regressed, maybe because there was some successful drainage or backflow of the mucus back into the cecum, or for whatever reason, the inflammation settled. The appendiceal lumen only has very clean mucus, very sterile mucus, and then all the symptoms abate. So what are the different things that can happen from a patient having an acute appendicitis? Just like we've tried to explain, I'll just run through it. There could be resolution, whether spontaneously or with the use of antibiotics, and we understand how this can resolve based on the pathophysiology that we've explained. An abscess can form. The abscess can, if the policeman of the abdomen doesn't get to the appendix in time. There are many reasons why that will happen. If that happens, an abscess can form just beside the appendix, just beside the cecum. It can move into the pelvis as the most dependent area. If the patient is lying supine, it can track down the right paracolic gutter, can get into the subhepatic space, and get just beneath the diaphragm. And in some cases, just like Thursday, we did a case, the pus was found in all the quadrant of the abdomen, pus in the pelvis, pus in the right, in the parasacral area, right paracolic gutter. There was pus surrounding the liver. There was pus around the spleen. There was pus in the left iliac fossa. This can happen. And of course, that is because of the perforation they have there. And in that type of situation, we say the patient will probably represent with a generalized peritonitis. The appendix, the whole appendix can become gangrenous, not just the tip. The tip is the most, um, the tip based on the end artery form of supply is the one that is most prone, but the whole appendix can become gangrenous. There could be an appendiceal mass, which is the phlegma that we discussed. Sometimes the infection can track through the appendiceal vein back into the portal vein into the liver. And there is a term, subacute appendicitis, chronic appendicitis. I think recurrent appendicitis, subacute appendicitis, chronic appendicitis, I think they all form a spectrum of the same thing. Basically, someone had with appendicitis, resolved for whatever reason, came back, resolved for whatever reason, and then we said the patient has maybe chronic appendicitis. Now, what makes the appendix, or what are the risk factors why an appendix will perforate very, very early? There are some patients that will tell you, oh, the history started yesterday and you go in for the surgery and you find pus everywhere. How come you perforated in just 24 hours? Is the patient lying about the onset of symptoms? Maybe, but sometimes in the extreme of ages, when a child has acute appendicitis, you better operate early because it is going to perforate very early. Elderly patients, patients that are immunosuppressed, there's nothing stopping the inflammation going on. Diabetes mellitus, we know why that would be. And of course, a fecolate obstruction. So if the cause, so if we do a scan, even an ultrasound, and they tell you, oh, this patient has active appendicitis, and not just that, we could actually visualize the fecolate. Then you know this will most likely perforate if not treated because the fecolate is not just going to dissolve. It has calcium, it has everything. So it will probably progress through the continuum of the pathophysiology. Is it a pelvic appendix? A pelvic appendix is not surrounded by anything. It's very hard for the policeman of the abdomen to go and contain that may likely perforate easily because it's just very free, dangling down. Previous abdominal surgery, because the greater momentum has already done a lot of things, is already added, a lot of addition has stopped the migration of the greater momentum, and that can also cause early perforation of the appendix. Obesity, because you don't detect it in time because of so much fat, there is no localization. Even though there's localization, you probably need a very deep palpation to be able to get it, and before you know it, you've wasted time on this perforation. Everyone knows the typical history of appendicitis. Starting periumbilical, moves to the right iliac fossa. But I think the message I will pass will be that this only happens in 50% of cases. 5 out of 10. The other five will just tell you, I noticed the pain in the right iliac fossa and it has been in the right iliac fossa since. Maybe 40% will say that. Then the other 10%, the 1 out of 10 will tell you, well, it's the whole lower abdomen. The pain started in the whole lower abdomen and it is still the whole lower abdomen. But one symptoms which I'm not usually happy when an individual clacks a suspected acute appendicitis and did not ask for anorexia, because this is like the most common feature. Like we said, the migratory pain is only present in about 50% of cases. Anorexia has been shown to occur in about 80 to 85% of patients, and I think that's the most common history or symptoms of acute appendicitis, anorexia. And that is why we have the famous hamburger sign. The hamburger sign is when you ask a patient, what food do you like most? And they say whatever. It is called hamburger because I think a lot of children in the Western world likes an hamburger. And once they tell you and this, you ask, oh, okay, do you feel like eating this particular food now if we bring it to you? And if they say, oh, no, I don't feel like eating it, why would you not want to eat your best food? Probably because you're anorexic, and that means a positive hamburger sign. Nausea, most patients are actually also nauseous apart from being anorexic, and they will usually have 1 or 2 episodes of vomiting, especially in children. If a patient presents to me and is telling me I've vomited about 10 times, my mind is already biased. This cannot be acute appendicitis. If you will be vomiting, not so much. Pain in the right iliac fossa, of course, I think that is also one of the most constant symptoms, whether it was migrating or whether it started there, it's still there. Cough makes it worse, moving makes it worse. You want to just stay still because you don't want to move, then yes. Fever. Even though we say fever is present in acute appendicitis because, of course, it's an infective process, I think you should know that early appendicitis will only cause a mild fever. An uncomplicated appendix will only cause a mild fever. So usually I get a referral from ED and they are like, oh, this patient is having lower abdominal pain, fever of 40 degrees, started this morning. Oh, pain started this morning and you're having 40 degrees. Or pain started yesterday, you're having 39 degrees. That's high fever. I wouldn't expect that from a non-complicated acute appendicitis. And I would not expect a 24 hours acute appendicitis to have been so complicated that you're already very septic, having 39, 40 degrees. So usually, if a child especially comes with a fever greater than 38.5, most times appendicitis is usually less than 38, but if they are coming with a fever greater than 38.5, I will be thinking of something else. But if they have fever and still tender in the right iliac fossa, then the diagnosis will probably be mesenteric adenitis, and that is inflammation of the lymph node present within the mesentery of the abdomen. Ultrasound can actually give you this diagnosis because the lymph node will be very enlarged, more than normal, and there will be many of them, and they usually present with a very high fever. And we see that a lot. But still, we still do the ultrasound because at least it will also give us the diagnosis of mesenteric adenitis. Some people may tell you they've had this type of pain before. Well, that doesn't mean it's not acute appendicitis. Like we said, there's a term called recurrence of acute or chronic appendicitis. So maybe, just maybe, and there might be positive family history. All these are not more really important, but the few history is given above is the main history that you would get from a patient with appendicitis. Sometimes it can be atypical, maybe 10%, usually in adult. Oh, my pain started in right iliac fossa and it's still in right iliac fossa. That means it's predominantly somatic, or it could be predominantly visceral and it's polylocalized. Oh, well, the pain is just around my umbilicus. And yeah, I can't really describe it. Yeah, fine. But it could still be acute appendicitis, just very atypical. If the inflamed appendix is a pelvic type, just lying on the bladder, on the rectum, or the free space between the rectum and the bladder, Mm. That could cause suprapubic tenderness. That could cause the rectum to keep twitching, that is tenesmus, and they can be passing loose stool and still having the urge to pass more stool even if nothing comes because of the twitching tenesmus of the rectum because of the inflamed appendix on it. But sometimes we'll get this through rectal examination. Some of the signs include fever, tenderness, guarding, which we've said. Rebound tenderness is very important. A lot of signs has been described, rupturing, sores, obturator. Some of the signs are depicted here. Sour sign means you hyperextend, and while hyperextending, you are stretching the swaz, and the appendix lying on it will get displaced, and that causes pain. Obturator, the patient flexes the hip, internally rotates, and that's the obturator, and the obturator touches the inflamed appendix, and there is pain. The one the ED physician like a lot is the ropsin. You pray the left iliac fossa, and then the patient has pain in the right iliac fossa. We've discussed about the different presentation based on where it is. Some people have diarrhea because of the position of the appendix, which you said also. Appendicitis in pregnancy is something we see also, usually one in every 2,000 pregnancy. It is the most common acute abdominal condition in pregnancy. It might, well, it should be remembered as a differential diagnosis in patients who are pregnant with abdominal pain because it is associated with about 3 to 5% fetal loss. And in many of them, the appendix can also perforate, and that also is very important because a perforated appendix increases the risk of fetal loss also. But the way we diagnose it is that most times the cecum is not so mobile. So even with the pregnancy, the typical right iliac fossa pain and tenderness will probably still be there. And a lot of differential diagnoses are there for acute appendicitis, gastroenteritis, mesenteric adenitis, naked diverticulitis, which needs to be suspected in surgery when the appendix looks normal, intussusception, lobar pneumonia on the right. In adults, any other form of enteritis. I do have a lot of urethric colic, especially when the stone is now in the VUJ. The pain is localized in the right iliac fossa. Perforated peptic ulcer, I think this is what we call the Valentino sign, when the perforated gastric or duodenal ulcer and the content migrates to the right paracolic gutter down into the right iliac fossa and you feel the tenderness there, whereas the patient has a perforated peptic ulcer. Torsion, you should always check the testes in appendix, especially in children for torsion, because sometimes they can't really tell you, oh, there's also pain in my testes. Female ovulation pain, PID, UTI, ectopic pregnancy, you should always do a PT test for a female in their reproductive age. I think whether they are on contraceptive or not, we just have to do a pregnancy test. And in elderly patients, I think the one we should take note of is the diverticulitis and also the colonic carcinoma. In elderly, they have a lot of diverticulitis that mimics acute appendicitis. I have seen someone taking a diverticulitis to theater because he said he made a clinical diagnosis of acute appendicitis, and in surgery, appendix was fine. The sigmoid colon was extremely inflamed. The sigmoid colon can flop and move around, causing left iliac pain, right iliac pain, suprapubic pain with elevated white cell, of course. Colonic cancer, especially the cecal cancer in elderly, can also cause pain and also even cause appendicitis. And everyone should try and know the Alvarado score, also called the Mantel score. The Mantel score is a mnemonic for us to remember the what are the things that are scored in Alvarado score, in mantra, MENTRELS, and these are the score. And it's just the typical symptoms. If these are the only things you ask from your history, I think your history is good enough. Is it migratory lactosa? Is there anorexia? Is there nausea? Is there vomiting? On examination, is there retral lactosa? Is there localized peritonism with rebound tenderness? Is there fever? Is there elevated white cell count? White cell count is usually elevated in about 90% of appendicitis. So this is the most common score, and I think we should familiarize ourselves with it. It can also help you to judge if a patient has appendicitis or not. But then over the years, there have been a lot of other scoring. Most of them resembles the Alvarado score, appendicitis, appendicitis score, and a lot of others. In terms of investigation, routine investigation, full blood count, leukocytosis is in 90%, serious proteins elevated, EIU in preparation for surgery, pregnancy test in female, group and cross smash in case you want to do surgery. Most anesthetists will not let you do an appendectomy without having at least one group and safe. Abdominal X-ray, most times we don't do it, but if there's an ficolate, the ficolate is also called appendicolate. Then you might see that if the appendix has ruptured already, you may have some free gas. Ultrasound, most times, especially in children and teen adults, so with an obese abdomen, you might not be able to get an ultrasound. Ultrasound sensitivity is about 80%, 70%, different studies. And how we will know, usually the appendix will be about 8 millimeter or more in diameter. That means it's distended and dilated, and some other secondary changes of acute appendicitis, which we might look out later. If we want to, if anybody is interested, we can always come back to that. CT scan can also be done, especially in older patients, because in a lot of older patients, you think they have acute appendicitis. They are not in the age range of acute appendicitis, even though it can occur. You need to rule out, could it be diverticulitis? Could it be intestinal obstruction with sacral and dilatation and pain? Could it be a sacral pole tumor? How about an MRI? And an MRI can also be done, especially in children if the ultrasound is not conclusive, and also in pregnant women if the ultrasound also is not conclusive. But usually we probably do an ultrasound first in both groups. Well, this is CT scan, very sensitive, and there's a lot of research going on that all patients with suspected acute appendicitis should have a CT scan. In the Western world, in the United States and many other places, they are trying to ensure that all patients with suspected acute appendicitis have a CT scan because ultrasound keeps missing acute appendicitis because it's operator dependent. Even though you are very skilled, there's still about just 80% and you miss the 2 out of 10 that can end up perforating sepsis. And you say, oh, the ultrasound already said there's no acute appendicitis. So CT scan, very important these days. Ultrasound, this is the appendix, not dilated. But as we move on, there's something here, and then the distal part is dilated. That will be an acute appendicitis, maybe of the tip. This is a stone with an acoustic shadow. That will be the ficolate or appendicolate. This is the CT scan. If we look here, we can see this dilation here and the fat stranding. I don't know if we know what fat stranding is, but this black stuff here is the fat. That is the normal color of fat. Wherever this normal color of fat changes to this whitish area, that is called fat stranding, and that is inflammation. So inflammation with a structure here that is dilated and blind ending, that will probably be the appendix because the second will be somewhere here in the right. That's appendicitis. Same here, you can see this distended structure coming from somewhere around the cecum here, and you can see it has two appendiculites, one here, and this is probably the one causing obstruction because the dilation starts here, and there's another one there. So that will also be acute appendicitis. In terms of treatment, um, majorly all over the world, it is accepted that appendectomy should be the treatment. But however, you can also support the patient, especially if the patient is septic with intravenous fluid antibiotics and it gives you antipyretic. But recently also there is a lot of study, if especially if you're in the UK, there's the CODA trial that compared what if we don't do appendectomy for our patient, what if we just do antibiotics? And it has bring a lot of interesting results, and about 25%, 75% of patients with antibiotics will actually recover and don't need surgery. And the recurrence is the study, different study with different data, but most times about 25% of patients you treated with antibiotics, that is one out of four, will come back with appendicitis the next year. So I think that is very important when consenting our patient. Oh, you don't have to have surgery. Antibiotics also works in up to 90% of cases, but even though it works and you're able to go home pain-free, in the next 1 year, there is a 1 in 4 chance that you come back with appendicitis again. A lot of study. We talked about what an appendiceal mass is. We talked about what an appendiceal abscess looks like. We said that because then, how do we then manage a complicated appendicitis? If, even though we know non-complicated appendicitis, we go and remove the appendix. What if there's an appendiceal abscess? An appendiceal abscess, you really don't need to do surgery. You can just drain the abscess, ultrasound guided, CT guided, or you can go in with the mindset of removing the appendix. You drain the abscess, then you then excise the appendix. Sometimes you go and you don't see the appendix because it has formed a mass, but you can see the abscess and you can drain. Gangrenous appendix. Luckily, most times the gangrene is distal to the stone, so there is still a stone left that you can tie. Occasionally, the whole appendix is gangrenous, and then that there is a problem there. If you remove the appendix, there's no stone for you to tie. There are a lot of things that we can do. Some people in a resource poor country can do a right hemicolectomy. For some people, they can put a GI stapler, an intestinal stapler, across the base of the cecum just to close the hole, and a lot of other things. Ruptured appendix, you can toilet, pour a lot of water in it, uh, solution to pollution is dilution, and then remove the appendix after you irrigated well. Then there is something called the appendiceal mass, which you've said, which is the phlegmon, and there's something called Oluwasina regimen. This is not usually used anymore, but I think it's still something that we need to know. You are not meant to do appendectomy if you think the patient has an appendiceal mass because you can't even see the appendix. Everything is rolled up in the greater omentum with pus and everything. So most times you just treat conservatively. And the process of treating conservatively is called optional sharing regimen. But if it's not success, if you're not successful, that means the vital signs keeps increasing, patient keeps spiking fever, abdominal pain is increasing, signs of general peritonitis, then you need to do an open surgery, probably a right appendectomy. These are the things we do in surgery, a lot of different incisions. Laparoscopic appendectomy is what is recommended worldwide for all sorts of patients, whether pregnant patients, children, adults, where you put 3 ports in. 1, 2, 3. This will be the camera. You can see the light from the camera, and the 2 will be your working instrument. Usually, this will be the picture you will see. This will be your 2 working instrument, and that is the appendix. This will be the cecum. And we don't really want to talk about appendectomy, but these are just things about appendectomy. And we've talked about appendiceal mass, the ostinatial regimen, and what it entails, managing conservatively with IV antibiotics. Keep checking the vital signs as frequently as you can. Ensure an input output. Examine the abdomen regularly, recommended twice a day to be sure that the abdominal pain is not improving. Signs of generalized peritonitis is not visible. Mark the limit of the mass. If you can palpate it, you mostly would not be able to palpate in an obese patient to see if the mass is increasing despite your conservative management. If there's an abscess, you can always treat the abscess, ultrasound guided or CT guided. You don't need to do surgery. And again, something called interval appendectomy, in which you do 6 to 8 weeks, has also been abandoned. Most people also don't do that anymore. Once the flare has gone, you just let it be because it has also been seen that a lot of patients do not have appendicitis again in their lifetime. So there's really no point. If you have appendicitis, fine, we'll remove it. But if not, let's just leave it. We've talked about what makes us to abandon conservative management. And if the patient that had appendectomy is ill, we take history and examine just like any other surgery because the cause of the fever and being unwell can be from anywhere. Postoperative complications, wound infection, abscesses in different places, paralytic pilus, atelectasis, clots, enterocutaneous fistula if the stump is leaking. Many years, they can always develop adhesive bowel obstruction. So I think in conclusion, because the time is fast spent, in conclusion, acute appendicitis is probably not preventable and this will continue to occur. I'm sure a lot of doctors in this group, some of us will probably have had appendectomy before, but it's just very common and there's nothing we can do to prevent it. So surgeons need to continue to learn more on the different surgical techniques required in this management, and a lot of research will keep on ongoing to see what other way we can manage appendectomy, what other way we can manage acute appendicitis. Thank you very much. And thank you.
Awesome. I was so soaked in that teaching. I thought I knew a lot about appendicitis and appendectomy, but looked like I'm still learning. That was very, 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 very comprehensive. Uh, Thank you, Mr. Oyekan, for that amazing presentation. I learned a lot personally, and I'm sure every other person has learned at least one or two things from what you've spoken to us about today.
Yeah.
Yeah.
Before we take questions, I think I'll just quickly go through the poll and see what
Yes.
we thought
Yes.
before
Yes.
the
So
beginning of the
yes, apparently, yeah, that's the next thing to do. So we've got some questions, but I believe addressing the polls first might
yeah.
actually answer many questions already. So I know some of the questions has already been answered if you were very attentive. Some of the questions you would have gotten answers to them in the course of the teaching. But yeah, the speaker will just address the polls now one after the other and would take other questions afterwards. Thank you.
Yeah, thank you very much. Looking at the poll now, I think the first question I have here is what type of organism is usually cultured in acute appendicitis? And I think, like I said, acute appendicitis is a very popular topic, and 42% said it's probably a mixed flora, which we probably saw during the presentation, and that is absolutely right.
Sorry,
The
sorry to interrupt. The first poll is actually acute appendicitis can resolve by itself without surgery or use of
okay.
antibiotics. If you go up a little bit more.
Yes, I can see that. Yeah, about 78% said yes, that it can resolve, which we've already said, especially if the pathophysiology, if it is the non-obstructive cataract form of acute appendicitis, where the obstruction was caused by the lymph node aplasia, occluding the lumen. If the viremia resolves, then that of occlusion can resolve and the appendicitis can resolve. Then we've talked about the organism involved. We talked about which of the following can cause acute appendicitis, except, and yes, again, everyone picked excessive large meal, about 81% said excessive large meal. Yes, that would not be a cause. But picolate, worms, fruit and vegetable materials, sickle food tumor, all this can cause obstruction of the appendiceal lumen and cause acute appendicitis, which you've also said also. Then we talk about a 3-year-old boy with a day history of abdominal pain, 40-degree fever, had an issue of upper respiratory tract infection, was tender in the right iliac fossa, but there was no local peritonism, white cell was normal, and 94% of people think it's probably another diagnosis. And I'm sure we'll explain that also. A day history, 40-degree active appendicitis that is non-complicated, less than 24 hours of onset of abdominal pain, will probably not have a fever of 39, not to talk of 40. But still, we can also always still do an ultrasound, and the ultrasound will confirm the diagnosis, which is most likely mesenteric adenitis. And finally, the 70-year-old male who had all the signs and symptoms of appendicitis, and you wanted to confirm, and there is a tie between ultrasound and CT, abdomen and pelvis. I don't know if I think with the presentation, people will probably choose something else now. However, 70-year-old with classical presentation of acute appendicitis, we don't do an ultrasound. I'm sure even the consultant will not be happy that you did an ultrasound for a 70-year-old with cases of acute appendicitis. What we usually do is a CT scan, abdomen and pelvis to rule out especially a tumor occluding the appendiceal lumen or a diverticulitis, which is very common within the age group. But any which way, we would probably, after discharge, also do, there's a question like that, we'll probably, after discharge, also do a colonoscopy. Even though the CT scan doesn't show a tumor, we still do a colonoscopy because the CT scan can always miss a tumor. In fact, CT abdomen pelvis is not the gold standard for picking out a bowel cancer, a colonic cancer. And I think that's the end of the poll, so we can take questions now.
Yeah, all right. There was one other question that we didn't put on the poll, the 20-year-old one. Could you address that, please? I think some people put in the chat box that ultrasound. I think everyone
Yes,
that answered that said ultrasound in the
yes.
chat box.
So yes, exactly. So
You can just read out the question to them so that
yeah.
they can know which one we are addressing now. If that's all right, please.
So if we look at this question, we said a 20-year-old male with migratory right iliac fossa pain, fever, nauseous, anorexic, had a bound tender in the right iliac fossa, also has leukocytosis. Then how will we confirm the diagnosis? Obviously, just like everyone has said, we will need to confirm the diagnosis with an ultrasound. There's no need to do a CT scan for a 20-year-old. We're not really thinking of any major pathology in the right relationship, especially in a male. Even if it's a female, ultrasound will still be the best because an ultrasound will still tell us about an ovarian pathology. Even though it might not be as accurate as it sounds like general ultrasound, but an ultrasound in this age group will definitely be the way to go. Um, yeah, we've already talked about what single most important outpatient investigation with this patient have. So usually there is a debate within what the cutoff should be in converting from ultrasound to a CT scan. For most people, anyone above 40 should have a CT scan because colonic tumor will start around 50. So if someone is above 40 with acute appendicitis, and we've already said it's more common within adolescents, early young adults, anyone above 40 should probably have a CT scan. And I'm sure if you ring the radiologist, they'll probably agree to do a CT abdomen approach. See if you tell them you think it might be an acute appendicitis in someone almost 50. I also said that in pregnant women, laparoscopic appendectomy is still what most people will do. If the uterus has pushed away the appendix from the rectal left side, it's very easy to tackle compared to if you do an open in the Marbonis point and you don't find the appendix because the uterus is pushing a very mobile cecum up into the subhepatic region. But of course, you can always do everything. You can do anyone, open, laparoscopic, in any young, old, pregnant, non-pregnant. If you don't have the expertise for laparoscopy, open is very well okay. We already talked about the constituent of the mass of the appendiceal mass, and we also said a little about how to manage an appendiceal mass. So if you have an interview and a patient is pre-appendicitis, a CT scan confirm a mass, it is better you tell them you will not manage operatively. Thank you.
Awesome. Awesome.
So I think someone said, is there any atypical symptoms in diabetic patients or who have neuropathy or are having either chemo, radio? I think just like we said, even though even though they are diabetic, they are immunosuppressed for whatever reason, they might still present classically. However, there are a group of people that will still present atypical. And most times, you can have a patient telling you, I'm having low abdominal pain. And then you examine this patient. This patient is not tender at all in the tummy, but the patient is immunocompromised for whatever reason. Immunosuppressive medication from transplant, chemo or radiotherapy, but they complain of abdominal pain. Usually, they complain of abdominal pain. with a rise in white cell should warrant a CT abdominal pelvis to rule out any pathology going on because you can't really assess them. The local irritation in the right iliac fossa is usually due to you being immunocompetent because that has to do with all the cytokines and everything being produced by the white cells and everyone trying to fight infection. If you're immunosuppressed, you can't fight the infection, your appendix can be inflamed, and there's nothing to suggest it on examination because the peritoneum, the parietal peritoneum, the right iliac fossa is not inflamed. You can't respond to the inflammation. So typical, atypical will still be patient is nauseous, complaining of abdominal pain, is anorexic, blood at the veins, elevated CRP white cell. Then you probably need to get an abdominal pelvic scan. Then someone told me to clarify, someone put in the chat box to clarify the pathophysiology of the migration of the pain in appendicitis. I remember this was a very common question in my anatomy days. So usually the appendix or the bowel generally, the foregut, midgut, hindgut, they usually their pain fibers are usually autonomic, meaning what carries the pain sensation is usually sympathetic or parasympathetic, but most times the pain is from sympathetic. And sympathetic to the abdomen, to the bowel will be from the splanchnic nerve, but most especially the one to the appendix is the T10 sympathetic nerve fiber that takes it to the spinal cord, to the CNS. And we know that the dermatome for T10 is around the umbilicus. So when there is a visceral pain, pain from stretching or ischemia of the appendix, the T10 sympathetic fiber carries it to the CNS, and the CNS reads it as a somatic pain occurring in the dermatome of T10, and then you have pain around the umbilicus. But once the inflammation in the right iliac fossa progresses, the mere fact that the appendix is touching your anterior abdominal wall, is touching the peritoneum, the parietal peritoneum of the anterior abdominal wall, that inflammation in the appendix will cause the parietal peritoneum to also be inflamed. Parietal peritoneum is somatic and that experience pain. Appendix itself does not experience pain because it's visceral. If it stretches or is ischemic, that's the only pain that bowel can feel. And if, for example, if we don't do bowel resection and anastomosis while the patient is awake, but I can tell you, if a patient is awake and you bring the bowel out and you cut the bowel, the patient will not feel any pain because that type of pain is not felt by the visceral. The visceral pain is usually from distension. But the parietal peritoneum, the inflammation from the appendix that touches the parietal peritoneum makes a very distinct pain in the right iliac fossa. And when you disturb that parietal peritoneum with pressure, the patient has a lot of pain. And by that time, the CNS forgets about the very dull visceral pain occurring in the periumbilical and concentrate on the real severe pain in the right iliac fossa. I hope I try to simplify that as much as possible. So someone said, would non-radiating MRI scanning be more sensitive and safer than CT when treatment for possible malignancy. Yes. Okay. So now the thing is that when in the setting of acute appendicitis, no one really urgently goes for an MRI, even though an MRI might be sensitive. Normal, I think we need to first let's take it one after the other. I think the first thing will be that always remember that this is an acute situation. In acute situation, CT is always the gold standard. MRI takes time. You don't want to put a septic patient with active appendicitis there. Two, MRI is always very expensive. Even the hospital do not want people queuing to for MRI, even though they can, as long as they can get the diagnosis they need from another form of investigation. In terms of it being safer, fine. In terms of it being sensitive, I think CT scan in diagnosing acute appendicitis has been recorded to be up to 100% in some studies. So, in terms of being very sensitive, it is comparable to MRI in all form, CT scan, abdominal pelvis, and MRI. But in terms of being safer, maybe, but in the acute setting and the price of MRI and the time it takes for MRI, maybe CT scan will still be the go-to. And most times, colonic tumor are not to be treated immediately. They usually go to an MDT before a decision is made. So CT scan, colonoscopy as outpatient will probably still be better. And that is the guideline anyway. I think that's all of the questions. If anyone has any other questions, I'm happy to.
Awesome. Apologies. I think I sort of got cut off for a few seconds at some point, so I had to switch to another gadget. Anyways, I think we're all caught up with the questions in the chat box. We've talked about the polls, and Mr. Speaker has kindly gone through them again to clarify everything as far as I'm aware. And all the questions in the chat box, I think, have already been answered. So it's safe to say we could wrap up this session very soon. If there are still other questions, probably someone is still typing and wants us to give them a few more minutes, we can, because we're just going to be talking about further sessions that we'll be having in the next couple of minutes. But before then, yeah, I really enjoyed today's teaching and I learned a lot. One thing I've learned today is if a child or even an adult is vomiting quite a lot in the background of every other thing, that should point your attention to something else rather than appendix. But do not rule out appendix totally. Have a low threshold because, of course, common things occur commonly. So still go ahead if you think there's a chance for it to be appendix. If it's not clear cut, go ahead to do an ultrasound or a CT, depending on whether it's a child or an adult, and depending on their age, basically, and other symptoms and signs you've elicited. Also, I think I've learned about even the in our setting back in Africa, it's not routinely done. Colonoscopy should be something. It's like an added investigation you can do for someone you're suspecting to have appendicitis, not necessarily as an inpatient. You can get that done after you've discharged the patient. Even after you've chopped off the appendix, you can actually go ahead, book them for colonoscopy in the next couple of weeks to rule out any tumor. Because to be honest, you can miss that. You can really miss that, and you just think it's a non-specific abdominal pain, or even though you might go in and see that the appendix is mildly injected, it could just be a reaction from the tumor that is causing that. So it's and CT scan is not the best in diagnosing colonic tumors. Colonoscopy is better. So amongst other things, I think everyone else has actually learned one or two things as well. Thank you very much, Mr. Oyekan, for that lovely presentation. I don't think, okay, the other question that I think it hasn't been answered yet is about the slides. I'm not sure whether when I veered off for a few seconds, you've answered that. Someone asked whether the slides will be provided. I've only replied in the chat box that normally if the speaker is happy for the slides to be shared, then we would upload it on Medal as a catch-up content. And of course, for the recording, for the recorded version, I think someone asked about whether it's gonna be recorded or not. Yeah, that's all our sessions are recorded, so you should have an access to that at some point later today or tomorrow, at the latest. So I would let everyone else. I don't think there is someone. I think I just saw a chat pop up now. Let me have a look whether it's a question. Please invite me to your future classes. Hoping to review your video. Of this. Okay, yeah. Thank you very much for that. All of our subsequent sessions would always be published and broadcasted on all the communities, or in all the communities. If you're a member of SIGAV, definitely you should get an invitation. And if you're not a member of SIGAV, I will enjoin you to join via the link sigav.org. I've popped that onto the chat box earlier on, and I'm doing that again now. If you check the chat box, you should see the link to SIGAV if you want to join, if you are not yet a member. And you've got access to all of our teachings, mentorship, and also research activities. So once again, thank you, Mr. Speaker. Thank you, everyone, for joining us and waiting till the end. I know this is weekend, and you could have just used this time to do something else, but you've sacrificed these few hours to join us, and I'm sure it's worth it. Feel free to email us, or you can get onto the website and you will see all the contacts of the leads and the executives there. Feel free to email any one of them if you have further questions. Thank you very much, and we'll call it a wrap now, as there are no other questions. Someone is asking about this account has been suspended. I'm not sure what that is all about. Can you make it clearer, Dr. Adi? What do you mean by the account has been suspended? Is it your account or someone else's account? Oh, do you mean the link to SIGAV? Oh, I see. I see what you mean. Let me have a look. That shouldn't be, except it's a new development. 1 second. I'll just have a look. Okay, I think you're right. There must be a glitch. I would feed that back to the technical team. That must definitely be a glitch. The website was still working earlier today, so I think something must have happened. Probably the traffic or whatever. I'm not sure, but I'll get that sorted. Thank you for raising that, Dr. Adi, and hopefully the website should get back and running very soon. But I'm definitely sure it's just a glitch. Thank you, everyone. So we'll call this a wrap, and I'll say a good evening to everyone. Thank you to our speaker again, and we will see you all at our subsequent sessions. Have a good night. Bye.
Thank you. Bye.